Welcome to CareTalk at Health 2019, a special series of interviews at the Health Innovation Conference in Las Vegas. I'm David Williams, president of Health Business Group, here with my co-host, John Driscoll, CEO of CareCentrix. Today we have a guest, Andy Slavitt. He is chairman and founder of the United States of Care and former acting administrator of the Center for Medicare and Medicaid Services. Welcome, Andy.
Thank you, David.
So Andy, last night you gave kind of a lame answer when Mark Cuban was attacking the signal achievement of the ACA. I think he could have done a much better job defending the ACA. So you want to try doing a better job?
So look, first of all, I was trying to give Mark his moment. And I didn't want to do to him what I did to Paul Ryan when we did our public debate and make him feel bad. So I appreciate you giving me this opportunity. So Mark, here's the story. The ACA, like any piece of major legislation, we should think of it in the context of like we think about most major things we do. Get it about 80% right, and then the 20% that isn't right because the plan was good, but the reality was different and had unintended consequences. Congress is supposed to do what? Come back, fix it, do some technical corrections, and throughout history, you go all the way back to Medicare, to Social Security, to tax legislation, and people come back together and they fix what doesn't work. So what worked with the ACA, primarily, we created a new bargain with the American public. We basically said that if you're sick, or if you've ever been sick, if you have a low income, you're still entitled to buy health insurance. That's a major change. It's a major change, and our hope is we won't go backwards from that change. We also, incidentally, have significantly improved health in low-income communities, mostly through Medicaid expansion, and there's 20 million people more that have insurance. And then there's several things, a number of things that could have been done better that didn't work.
But I think what was really powerful is you changed the conversation, because before the ACA, pre-existing conditions was just a thing. It was a sort of structural part of the system. And by changing the conversation, you'd actually raise the bar or the barrier to changes that could take it back.
Right.
I mean, I think that the one of the thing, and then the other thing you've done in the ACA is you changed the way people thought about data, and really you sort of put there was a lot of resources that are bundled in to help reform healthcare that I think there's going to be a sort of a long road. In fact, some of the things that Mark talked about, the foundation for providing that data to reform healthcare is based on Obama initiatives that were all tied into how we're going to reform healthcare. So if that's all true, why isn't it more popular?
So the ACA wasn't merchandised very well at all. And look, this was before my time, and I'm not suggesting that if I were there, it would have gone any better. But the reality is the ACA did 9 popular things and 1 unpopular thing. The 9 popular things were all the things we've talked about. It put caps on ended lifetime limits. It said there's 10 essential benefits. It did all these wonderful things. There was one thing that wasn't popular, which was the individual mandate, which was actually something that the president didn't like to begin with. When the ACA rolled out, if they probably had to do it over again, it probably would have talked not about the whole thing, or about all these different component pieces, because it did so many good things. It closed the donut hole for seniors, it's launched ACOs, but it would have started talking about the most popular feature. It would have been talking about protections for pre-existing conditions. And rather than talk about the law for all of those things. Now, when the law became popular, and now it is more popular than it is not, it became popular when...
Is that true?
Yeah,
is that
that's absolutely true.
Okay.
It's absolutely true, but it's actually not true because of the law. It's true because people came along afterwards and said, we're going to get rid of it. And once people said we're going to get rid of it, people started to understand, well, what is it you're going to take something from me? You're taking away my right to change jobs, to have some economic mobility. You're changing the right of my 25-year-old to get coverage. So everything the Republicans are doing, whether it was in Congress, whether it was through executive order, whether now through the court system, where they're trying to get rid of the ACA, all those things make the ACA more popular each time they do it.
So Andy, I thought you're supposed to be a proponent of good government, and here I hear you calling for the deep state, which I thought was some sort of conspiracy theory. It was the deep state is supposed to help us in healthcare?
The deep state.
Aren't you part of the deep state?
So first of all, the deep state, right, who are they, right? They're the civil servants that work every day, regardless of political party, to serve the American public. And whether they're in the State Department, whether they're in the Department of Health and Human Services, generally speaking, these are people that could be making a lot more money if they wanted to work in the private sector. They're some of the best citizens we have. I think my point, and you're referring to a JAMA piece I wrote where I said the deep state can actually help us solve a lot of our problems in healthcare, is that it used to be, up until a few years ago, that if you wanted to make a major change in healthcare, you had to go to Congress. So you wanted to wipe out AIDS, you needed money from Congress. You wanted to pass interoperability, all those sorts of things. But Congress gave us 3 tools that now allow us to improve the healthcare system on our own. One is Medicare Advantage, which isn't perfect, but it gives doctors and patients the opportunity to do things innovatively that they've never been able to do before. The second is CMMI, the Centers for Medicare and Medicaid Innovation, which have launched 40 models that are finding ways to improve care by changing incentives. And the third are Medicaid waivers. And so the point I was making is that we now have, with some limited authority that Congress gave us, opportunities to move much more rapidly in improving healthcare. Now, that only works if people in the private sector and people in the government actually exchange information, work together, work transparently, and then iterate. Because no problem will be solved perfectly the first time. The first version of ACOs is like the iPhone 1.
Yeah.
Right? It does a couple things, but there's a whole bunch of things that could be better. We're still on ACO iPhone version 1.2. We're still on medical home version 1.2, bundled payment version 1.2. By the time you get to the iPhone 10, 11, 12, it will start to have the input of doctors, start to have the input of patients, and be a lot better. And that's what the quote-unquote deep state, people working in CMMI and throughout other agencies, can help carry out.
But you're really creating a different role for government to almost be a venture capital idea, in fact, to allow a lot of different pilots, programs, and tests to sort of determine how we can bend the cost curve. That was sort of an intriguing thing. And isn't that there's bipartisan support for that?
Well, look, I think any serious policy student in healthcare will at some point talk about improvement.
Yep.
They won't talk about a quality goal. They won't talk about like a metric.
Yep.
They'll talk about it in terms of improvement. And improvement means you make a change, you see what the impact of that change is, and you continue to change. And so to do that, you need a responsive system. So if it turns out that you make a change and some of it works and some of it doesn't work, and the government on the other end can't say, you know what, we're going to adjust the policy, we're going to create new rules, we're going to release a new model, then we just end up getting stuck with version 1.
Yeah.
And so you have to have a reactive government. And as much as
so
Congress...
a deep, agile state.
Yeah.
Deep, agile state. And by the way, look, the people who should be taking those roles, the people who should be going into CMMI, ought to be people who are in the private sector, want to go spend a few years learning what that's like, and then bounce back out. And those are the healthcare leaders of the future. I believe the best ones are going to be people that have experience both in and out of government. And we all know people like that. That's, you're an example of that, and in healthcare there's lots of examples.
But so Andy, the question then is, it sounds like you're trying to found a whole new government, United States of Care. Is that like some sort of separatist movement?
So am I supposed to look this way and then
we're supposed to confuse you.
Just answer the question. Just answer the questions.
Just look at the audience.
Look here. In the middle.
The audience cares what you have to say. We don't really care. Yeah. So
right.
United States of Care, is that
question.
United States of Care? Is that like some sort of breakaway government?
It's like Australia. Basically.
It's like that. That floated along
it's
distance
it's a bunch of convicts. Yeah. No, look, United States of Care, and look, there's not one tool that's going to solve our policy problems or our healthcare problems. I'm a problem solver. I guess that's how I would define myself. I think if you are an innovator or capitalist or venture capitalist, every problem you solve, you try to solve one way. You try to solve it by innovation, by investing. If you're in government, if you're a policy person, I'm looking at you. But
that's fine.
Then everything you try to solve by changing policy.
Yep.
If you're a hospital CEO, everything you do is by what you can do in your community. So the reality is, you maybe end up hitting a nail with like a screwdriver because that's the only thing you have.
Right.
So what I decided to do and we decided to do is to say we're not going to do that. We're going to go with some shock and awe and say we've launched a venture capital fund that invests in, we think, companies that matter, companies that are innovating in underserved communities. That's called Town Hall Ventures. We've also launched United States of Care, which is a movement that we launched with about 100 other national leaders in healthcare and business and innovation, patients, physicians, and they're focused basically on better policies. And sometimes, like you take a problem, so we're problem solvers. Take a problem like maternal mortality.
Yep.
Sometimes you need a little bit of innovation, a little bit of policy change, and sometimes you need a little bit of them both together. And I think US of Care plays the role of saying, how do we get to better policies so that we can all have what everybody wants, which is everybody gets a regular source of care, everybody is connected to the system, nobody has to choose between a medical expense and any other expense, and that's what the vast majority of the public wants.
Great. Well, Andy Slavitt, I want to thank you for being here. We have a special gift, a little orange man who you can name later for being on the show. Appreciate that very much. Andy Slavitt is a former acting administrator of CMS. He's also founder and chairman of the United States of Care. You can watch our entire interview series from Health 2019 on your YouTube playlist or listen to it on your favorite podcast service. And remember, subscribe to CareTalk.
Subscribe right now. Thank you.
What they said.
Hey there, listeners. Want more Care Talk? There's more to be had in our other episodes, so be sure to look for those and subscribe to Care Talk on your favorite service.